OCD, and they have a really fluctuating course. One of the things that you see when they have these big fluctuations is that they melt down, they have huge temper tantrums, they maybe become more aggressive, sometimes they even look psychotic. And this all occurs in the context of after having a strep infection. A lot of times they still have strep in their throat. They may be going to pee a lot, which is a common thing I see with the early onset of these kids. And so, if you were to sort of like, oh, they've had 2 or 3 weeks of explosive outbursts, and you went ahead and treated them with atypical or something that was more aggressive, a lot of times these kids get better, even certainly with antibiotics, and sometimes just on their own. They get better over the next few weeks. So you really wouldn't want to jump to psychotropic medications in these cases. So immune-based therapies a lot of times will turn a lot of the stuff around. The little boy that would bite every time he got strep, his strep was treated with an antibiotic, he stopped biting. So treatment, really there's no studies, so that's the easy part. When you see a lot of aggression in OCD, a lot of times it's really just truly because they're so stuck in the ritual, and the parent's like so fed up and so tired of washing something a gazillion times, or being late for something that they want to get to, and they're trying to get them to go someplace or to stop this, and the kid gets so frustrated they just blow up on the parent and become aggressive. So in that case, really what you want to do is treat the OCD, cognitive behavioral therapy, usual standard medications. I have had some kids that come to me, and this is just because I see these kind of kids, I wouldn't recommend this globally, but I've had some kids that come to me so catastrophically ill with their OCD that they can't do anything, they're almost catatonic. I often start with an atypical, but that's not most cases. And that does a pretty decent job, and then I add the SSRI and then take away the atypical as they get better. But usually the standard treatment approach for OCD and Tourette's would apply. So the rage symptoms in Tourette's, this is something that's pretty common. How much of it's due to the OCD and ADHD, I think that's still an issue that needs to be sorted out. But you want to look how often and how bad it is, basically. This is it's actually called the ROARS, but it's a rage assessment looking at the severity. And of course, if they're getting 7s and 9s, they're pretty severe. Comprehensive diagnosis, looking at medications, drug interactions, psychosocial functioning, usual stuff that we've talked about. Variety of different types of behavioral treatments have been discussed. I think any of those are worth a try. But I think, in this case, if you have a lot of, really pathologic aggression, you've gone through treating the primary disorder, whether it's tics or OCD, and you haven't gotten rid of the aggression, the rage episodes, then I would just kind of go by the TRE guidelines and probably eventually use an atypical. And the good thing about this option is because one of the primary treatments for severe tics is an atypical, so hopefully you'll get, 2 birds with 1 stone in that case. Different, options for treating rage episodes, then it really is going to apply to what's the more comorbid or primary cause for the rage episodes. Kathy Budman several years ago did a paroxetine one that showed improvement in rage episodes in patients with Tourette's, but majority of those patients also had OCD and majority had ADHD. So I think we have to kind of sort that out. I'm going to go over one of her studies, and this was using aripiprazole for rage in kids with tics. 37 children. She started out with 1.25 milligrams, which I like, and increased up to an average dose of 11.69. Most of these kids were also on a psychotropic. Most were male. She had some all the way up to 40 milligrams. And in my experience of treating tic disorders, if they don't get better past about 10, 15 milligrams, then they don't really show any significant response with the higher doses. So I really don't typically go that route. These are the comorbidity. About 78% of them had intermittent explosive disorder criteria, minus the C criteria there. A lot of them with ADHD, a lot of them with OCD. And this is a CGI rating scale that she used, 6 being very severe rage, 6 being severe tics. And then showing the CGI on tics getting better and pretty significant improvement in rage episodes. 21% discontinued the aripiprazole. Don't know that she said what dose these people were on when they discontinued, but the typical things that we see: akathisia, Parkinsonism, increased agitation and affective lability, and daytime sedation. Parkinsonism, I've only seen that when the kids get to really high doses. Akathisia and agitation, I often see that in the first 2 weeks. Usually it'll go away if you kind of can write it out and not really be aggressive with their dosing. Mild, otherwise mild symptoms. So, trying to enlighten you here, I think it's pretty common, when you see Tourette's and OCD, and particularly maybe the OCD that's a driving issue with the rage episodes in a lot of these cases. These are usually more complex cases. I would try the primary therapies first, which hopefully will get rid of most of the problems. And then if you don't get anywhere, combination strategies like the atypicals with SSRI, certainly the behavior treatments. And the only thing I would add is that we had kind of put aripiprazole in our original Tourette's guidelines as kind of iffy, and I think now we have better support than we did back then. And those are just some websites that I thought might be helpful. So.
Thank you.
Cool.